What's up everybody, Dr. Ryan here. I'm launching a new series of videos covering approaches to clinical examination. I'm really excited about this and hope this is a blessing to you. We're kicking off today looking at general examination. Let's go. So first up guys, you want to nail the following points, right? Talking about the nails, obviously. Okay, so normal nail growth is about 0.1 millimeters per day. And did you know that your fingernails grow quicker than your toenails? The nail plate grows continuously and slowly at a rate of 1 centimeter every 3 months. Therefore, it takes your fingernails about 3 to 6 months to totally grow out, and your toenails a bit slower, takes about a year or so, right? Rapid growth of the nail plate occurs in psoriasis, and nail growth is arrested by acute illness or ischemia, and it gives you characteristically what we call Bowes lines. You get bold and beautiful. We'll talk about that later, right? So how do we examine for clubbing of the fingers? So firstly, you really want to inspect whether gross clubbing is there or not, because that's kind of obvious. But if it's not that obvious, you want to look carefully at the angle between the nail and its base at the level of the observer's eye. Now the normal angle is 160 degrees. Anything greater than this indicates clubbing. Next, you want to check fluctuation of the nail bed, and we'll look at an image on how to do this. You want to place the corresponding opposite nails of both hands together and look for a diamond-shaped angle between those, what we call shamrod sign. If that is absent, that indicates clubbing. Then you want to look for convexity of the nails from side to side. In the advanced stage, you'll see drumstick or parrot beaking appearance. And if there's clubbing, you want to check those distal bones for hypertrophic pulmonary osteoarthropathy by pressing the ends of the long bones and looking at the patient's face. They're going to grimace in pain. So here we see the fluctuation test. Here looking for that diamond-shaped angle called shamrod sign by placing these two fingers adjacent to each other. If shamrod sign, or if that angle is obliterated, you could be sure there's clubbing there. Here we can appreciate gross clubbing, okay? Clubbing in the toes as well. This is a drumstick appearance, parrot beaking, and clubbing with cyanosis, which we will talk about. Alrighty. What are the grades or stages of clubbing? There's 4 to mention. Grade 1 speaks to softening of the nail bed with fluctuation due to proliferation of cells at the nail base. Then grade 2 speaks to an increased curvature of the nails, which become convex and the angle between the nail and its base are obliterated. Grade 3 is where we have increased pulp tissue, right, resulting in drumsticking and parrot beaking. And grade 4 is obviously HPOA. Right, what are the causes of clubbing among the middle-aged to elderly population? So a very specific group. We cut them into respiratory, cardiac, and others. So respiratory, bronchial carcinoma, commonly squamous cell type, probably one of the most common causes. Then suppurative lung disease. And examples are bronchiectasis, lung abscess, and empyema, quite common in our clinical setting. Then diffuse parenchymal lung disease is the new term for interstitial lung disease, right? And pulmonary TB, and more TB in the advanced stage with fibrosis will give you clubbing. Cardiac causes, infective endocarditis, and others being cirrhosis of the liver, primary biliary cholangitis, inflammatory bowel disease, and familial. What causes clubbing among kids? All the causes of clubbing among adults with their inclusion of cyanotic congenital heart disease, classically tautology of Fallow. And then when it comes to chronic liver disease, you must always think of this as well, the likes of Wilson's and alpha-1 antitrypsin deficiency. What important history should you take from somebody who has clubbing? Well, family history of clubbing. Do the parents also have clubbing? Right? Respiratory symptoms such as cough, hemoptysis, chest pain, breathlessness, cardiac history of cyanotic congenital heart disease, or does the patient have any cyanotic spells as a child, infective endocarditis, GI symptoms in the way of diarrhea or bloody diarrhea, which may speak to inflammatory bowel disease, and a history of liver disease. What is differential clubbing? It simply means clubbing in the toes, but not in the fingers, or vice versa. So what, pray tell, causes clubbing in the toes, but not in the fingers? A patent ductal arteriosus with shunt reversal, which interestingly also gives you differential cyanosis, an infected abdominal aortic aneurysm, and coarctation of that beautiful abdominal aorta. What causes clubbing in the fingers, not in the toes? It must be some pathophysiology in the upper limbs, but not in the lower limbs. Classically, chronic obstruction of veins causing phlebitis of the upper extremities, which is very common among IV drug users. What are the causes of clubbing in a single finger? Something we call unidigital clubbing. So that can be repetitive local trauma, which is by and large the commonest cause, but also we've got chronic trapezius gout, sarcoidosis, and median nerve injury. What are the causes of clubbing coupled with cyanosis? Well, I'm glad you asked. Diffuse parenchymal lung disease, which is ILD. Cyanotic heart disease. Then we have TOF. Now, TOF is not tracheoesophageal fistula. It's tetralogy of Fallot. Asomongous syndrome, where you initially have a left to right shunt and you have pulmonary hypertension and then reversal of the shunt to give you a right to left shunt with cyanosis, okay? Cystic fibrosis and, of course, bilateral extensive bronchiectasis. What is pseudoclabbing? So pseudo is Greek for false, right? So what causes pseudoclabbing? It looks like, smells like clabbing, but there is no soft tissue proliferation, nor is there any increased curvature of the nails. It's simply due to resorption of the subperiosteal bone and the terminal phalanges, and causes include systemic sclerosis and hyperparathyroidism. Okay, shifting gears, guys. What is cyanosis? Cyanosis simply speaks to a bluish discoloration of the skin and mucosa due to an abnormally increased amount of deoxygenated hemoglobin in the blood. By definition, you got to have more than 5 grams per cent of hemoglobin to be deoxygenated for cyanosis to manifest clinically. For the different types of cyanosis, we stratify them into peripheral and central causes. So peripheral is simply due to localized reduction of blood flow on exposure to cold, causing capillary vasoconstriction. We're getting smaller. We are constricting, right? Also occurs in reduced cardiac output with heart failure or shock. Now, the tongue, by definition, is usually spared in peripheral cyanosis because circulation to the tongue is usually very, 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 very good. Causes of peripheral cyanosis are exposure to severe cold, frostbite, Raynaud's, heart failure, shock and peripheral circulatory failure, DVT, and cryoglobulinemia. Don't cry, right? The central causes are either due to imperfect oxygenation of blood in the lung or an admixture of venous and arterial blood. And central cyanosis is evident when your oxygen saturation drops below 80 to 85%. It's best appreciated in the tongue. And the causes of central cyanosis can be divided mainly into respiratory, cardiac, and others. So respiratory, example, chronic obstructive pulmonary disease, severe pneumonia, tension pneumothorax, massive lung collapse, acute severe bronchial asthma, massive pulmonary embolus, pulmonary infarct, DPLD, ARDS, a lot of acronyms there, and respiratory failure due to any other cause. Cardiac causes of central cyanosis, cyanotic congenital heart disease, the likes of tetralogy of Fallot, transposition of the great vessels. We spoke about asomongous syndrome, where there's reversal of the shunt, right? And that can occur in the setting of atrial septal defect, ventricular septal defect, patent ductus arteriosus, acute left ventricular failure, and of course cardiogenic shock. Other causes include high altitude, which is a physiological cause of central cyanosis, as well as our beloved polycythemia. How do you differentiate between central and peripheral cyanosis? So we already spoke about the mechanism. In central cyanosis, it is generalized, but peripheral is more localized. The affected part in central cyanosis is warm, but is cold in peripheral. When you apply warmth, central cyanosis does not disappear, but peripheral does. When you give oxygen, cyanosis, which is central, may disappear in pulmonary disease, the one exception being a right to left shunt, but peripheral cyanosis more often than not does disappear. The tongue, by definition, is always involved in central cyanosis, but never involved with peripheral cyanosis, right? And why is there no cyanosis and severe anemia? Drum roll, please. Because we said that you need to have at least 5 grams percent of deoxygenated hemoglobin for cyanosis to become clinically evident. So if you have anemia, you may not have enough hemoglobin to deoxygenate, and that's going to mask your cyanosis. All right, shifting gears again, guys. What is jaundice? It is a clinical condition characterized by yellowish discoloration of the skin. See what I did there? Yellow. And mucosa due to excess bilirubin. By definition, we need at least 51.3 micromole per liter of bilirubin to be involved. Right. So serum bilirubin needs to be above 51.3. Jaundice should be seen in natural daylight. Bilirubin does have a strong affinity for elastic tissue, and we know that the sclera is beautiful because it contains lots of elastic tissue, also the skin. So jaundice, therefore, is best appreciated in the sclera. Here's a fun illustration from MedComic.com. Thank you, Mr. Muniz and company, illustrating our classification of jaundice. So prehepatic has something to do with destruction of red blood cells, and hemolysis, right? So transfusion reactions, sickle cell anemia, thalassemia, autoimmune disease. Hepatic has something intrinsically wrong with the liver, hepatitis, cancer, cirrhosis, congenital disorders, and drugs. Post-hepatic has something to do with the biliary system, so gallstones, inflammation, scar tissue, or tumors that block the flow of bile into those beloved intestines. What history is important to take in somebody who has jaundice? Well, viral or drug-induced hepatitis, obviously, if we have a history of drug use and if the patient has anorexia, nausea, and vomiting. Think about obstructive jaundice when the patient complains of jaundice together with pale stools and dark urine and pruritus, or itching, I want to scratch, hereditary hemolytic anemia, if there's a family history of jaundice, consanguinity in the family, or is associated with pallor, because pallor and jaundice more often than not equals hemolysis. Sexual exposure for hepatitis, history of injection, infusion, or blood transfusion, IV drug use, tattoos, and surgery, thinking about hepatitis B and C, history of travel abroad, thinking about hepatitis B, but more especially hepatitis A and E, because these are acquired via the fecal oral route and ingestion of possible contaminated food, water, milk, and so forth. History of alcohol, so alcohol is a big cause of jaundice. And remember, the pathophysiology of alcohol involving the liver progresses first through steatosis, then hepatitis, then steatohepatitis, and lastly cirrhosis. Okay. If there's associated fever and urinary complaints, you're thinking about leptospirosis. If there's recurrent jaundice with some kind of neurological abnormality going on, think of Wilson's disease. If there's associated abdominal pain and fluctuating jaundice, you want to think about a bile duct stricture or a stone. Okay, so guys, sometimes in medicine you can make a spot diagnosis just by looking at a patient's face. So some examples of these, this is the data from Macleod. Right, when this is hypothyroidism, the patient will have sparse, coarse hair and eyebrows, periorbital puffiness, dry, waxy skin, will look apathetic. In Graves' disease, the patients usually have a staring appearance due to lid retraction, proptosis, and evidence of weight loss. And there's a whole host of these: hypopituitarism, acromegaly, like Cushing syndrome with the lemon on a stick appearance, and the abdominal stria, the moon face, the buffalo hump, the plethora. Right, then we got osteogenesis imperfecta, systemic sclerosis, myotonic dystrophy, Down syndrome, and so forth. I just put this in here to make us aware that sometimes you can make a diagnosis just by looking at the facies of the patient. Right, regarding lymphadenopathy, normal lymph nodes may be palpated in the axilla and groin, usually up to 0.5 centimeters and are soft, rubbery, and shotty. Submandibular lymph nodes are usually less than a centimeter, and these are normal in kids. And inguinal lymph nodes up to 2 centimeters are actually normal in adults. Reactive lymph nodes expand rapidly and may be painful. Localized lymphadenopathy means a single anatomical area of lymph node involvement. Now, generalized lymphadenopathy is a very specific term which speaks to 3 or more anatomical non-contiguous areas of lymph node involvement. Enlargement of the supraclavicular and scalene lymph nodes are always pathological. So here we have our different groups. So we're looking at the cervical groups. We have submental, submandibular, then we have pre- and post-auricular, occipital, then we have the posterior cervical, and the deep cervical chain. Don't forget about your supraclavicular, right? Here we have the axillary group and the epitrochlea, the popliteal, and here we have the femoral group, all right? Important to look for stigmata of infected myocarditis. So we know here are Janeway lesions, right? And here we can see Osler's nodes. So Osler's nodes are palpable, but Janeway's lesions are not palpable. Osler's nodes are painful. Janeway lesions are painless. Here's your beloved splinter hemorrhages. Here's rot spot on fundoscopy, okay? And here we can see petechial hemorrhages. Tiny. Okay, what are clinical clues to secondary hypertension? Now, hypertension is common in our setting, but sometimes, right, 95% of the time it's idiopathic, but 5% of the time there's a secondary cause. Some clinical clues to pick up. If you're thinking about renal vascular disease or renal artery stenosis, the big tip-off is vascular disease elsewhere, and if you can pick up a renal bruit. Think about fail when the patient complains of paroxysms or episodes of sweating, headache, and palpitation. Think about primary aldosteronism, that's Conn syndrome, when the patient has hypokalemia. Cushing syndrome, when you make the diagnostic, facies apparent. And then we have Cushingoid facies, the lemon on stick appearance, so to speak. Central obesity, abdominal stria, proximal muscle weakness, chronic steroid use. Think about coarctation of the aorta when we have radiofemoral delay with low volume femoral pulses. And if you can palpate those kidneys bilaterally, you're thinking about our beloved ADPKD and our polycystic kidney disease. Right? Features of chronic liver disease, guys. So in a patient who has cirrhosis, they're probably going to manifest with jaundice together with findings in the hands being leukonoikia. cholynokia, palm erythema, and clubbing. In the chest, you're going to see gynecomastia in men and breast atrophy in women. Jaundice, we know, spiral nevi, especially in the distribution of the superior vena cava. In the abdomen, you're going to pick that splenomegaly, that hepatomegaly, and look for dilated collateral veins around the umbilicus, which speaks to caput medusae. Testicular atrophy as well. In the legs, we have edema and hair loss, and generally, we may have skin pigmentation, loss of body hair, and bruising. All right, back to the nail changes. What is cholynokia? It is characterized by a concave or spoon-shaped nail. Nobody really knows what causes it, but here we can see it looks like a spoon, doesn't it? What are the causes of cholynokia? By and large, iron deficiency, anemia, but also trauma in people who work with their hands. So garage mechanics, tire fitters, thyrotoxicosis as well. Remember, hyperthyroidism gives you this thing called thyroidopathy, which includes clubbing, but can also give you cholynokia, right? Fungal infection and Raynaud's disease. What are the stages of cholynokia? 1, 2, 3. So stage 1 has to do with dryness, brittleness, and ridging. Stage 2 is flattening and thinning. Stage 3 is spooning or concavity. What else do you want to know about? Well, if the patient gives a history of dysphagia and clinically has glossitis together with cholynokia, that's our beloved Plummer-Vinson syndrome. You want to do a scope to look for cricosophageal webs. What is leukonokia? The white nails. Leuko is white. It may be diffuse, punctate, linear, or striate with white transverse flecks, which is a common finding. May be normal, but often it indicates hypoalbuminemia from whatever cause, commonly from the kidneys being nephrotic syndrome, chronic renal failure, hepatic being chronic liver disease, cirrhosis, malnutrition can cause it. Others, rare causes are lymphoma, fungal infection. Striate leukonukia is a normal finding in minor trauma. And what does it indicate? We said it indicates hypoalbuminemia. What are the causes of nail fold infarct? Well, I'm glad you asked. Usually vasculitis, and more vasculitis due to any cause. So systemic lupus erythematosus, the wolf, dermatomyositis, systemic sclerosis, rheumatoid arthritis, polyarthritis nodosa. What are the causes of splinter hemorrhages? And we've seen these vertically orientated hyperpigmented lesions on the nails. Trauma is the commonest cause, but remember, always remember, systemic bacterial endocarditis, septicemia, collagen disease in the way of vasculitis due to lupus, rheumatoid arthritis, and polyarthritis nodosa. Others can be hematological malignancy, severe anemia, and psoriasis. What are the causes of so-called half-and-half nails, where the proximal part of the nail is white, but the distal part is red or brown? CKD, which is chronic kidney disease, cirrhosis, sometimes a normal variant. What are the causes of nail fold telangiectasia at the base of the nail? Lupus, systemic sclerosis, dermatomyositis, mixed connective tissue disease, Raynaud's phenomenon. Causes of Bowes lines. We mentioned this initially, right? It's a non-pigmented transverse line or groove in the nail due to transient arrest of nail growth. It appears at the same time on all the nails, and it indicates acute illness at some point. And causes are illness in the way of infection, malignancy, collagen disease, prolonged fever, pneumonia, CAD. Others being cachexia, malnutrition, psychiatric disease, and use for cytotoxic drugs. But the tip off here, guys, is it's non-pigmented versus Mees lines, which are pigmented and white. It's a single transverse white band in the nail, causes being chronic arsenic poisoning, CKD, also with chemotherapy and severe illness. Yellow nail syndrome is an inherited disease in which the nails are thick yellow, pigmented with separation of the distal part of the nail bed due to hypoplasia of the lymphatic system, which associates with lymphedema of the legs, bronchiectasis, and pleural effusion. Nail pitting is when your nail is depressed. Depressed, take some antidepressants. No, depression as in downwards, right? Causes include psoriasis, alopecia areata, atopic eczema, which involves the proximal nail bed, and pityriasis rosacea. Here are some beautiful pictures showing pitting with onycholysis, pitting in the toe, and pitting in the finger. Onycholysis speaks to separation of the distal nail plate from the nail bed, so much so that the free edge looks white, and causes are psoriasis. Plummer's sign and thyrotoxicosis can be idiopathic drugs like tetracycline and psoralen, porphyria, and trauma, or even a faulty manicure. Cherry's nails is where the proximal portion is white or pink, but the nail tip is red or brown due to a decrease in vascularity and increase in connective tissue deposition in the nail bed. Common causes being old age, cirrhosis, congestive heart failure, hyperthyroidism, malnutrition, and CKD. Beloved, I just want to encourage you this morning about seeking God. The prophet Isaiah tells us in the book of Isaiah, chapter 55, verse 6, "Seek the Lord while he may be found, and call on him while he is near." So seek him while he may be found. So this implies to me that indeed a time is coming when the Lord will not be found. Now is the time to seek him. Now is the time to pursue him, to get to know him on a more personal, intimate level. I pray that will be the cry of our hearts. Here are my references. God bless you and have yourself a wonderful day.